Welcome to the GHAPP MASLD and MASH Community Network. As Jennifer said, I am Christina Hanson, and we'll be taking us through this deck today. I'm a nurse practitioner here in South Denver, GI here in Colorado. If you haven't registered for the meeting, as people are coming on, use this QR code to go ahead and get registered. So this particular podcast today is going to go over MASLD pharmacotherapy. So as you know, MASLD is the new terminology, metabolic dysfunction-associated steatotic liver disease. We had our change in our nomenclature from NASH. Now we're using MASLD and MASH, which is obviously more consistent with what this condition is. When we have fat develop in the liver, we really have high risk when we have other metabolic comorbidities. So it's much more in line with the pathophysiology of fatty liver disease. So currently available treatments for dysmetabolic management. There's kind of three cornerstones of what we want to be working on. We want to control obesity. We want to reduce cardiovascular disease risk. We recognize that cardiovascular disease is really the main issue with fatty liver. The main risk that we have when we have fatty liver is really heart attack and stroke, even with simple steatosis without any fibrosis. So we really want to reduce that cardiovascular risk, and obviously more liver-directed targeted treatment for MASH. So again, weight loss still a cornerstone with diet and lifestyle, physical activity. This is still something that we want our patients to be working on, but we recognize that it can be very difficult for our patients to achieve and sustain these weight loss goals with diet and physical activity. So that's really where we start to look at what other ways can we help our patients achieve weight loss. And that looks into bariatric surgery for a select population of patients and weight loss medications, in particular the GLPs and in combination. So we know the GLPs approved for diabetes and more recently weight loss. We're definitely studying the GLPs. We're going to talk about that a little later on in the deck in the setting of MASLD and MASH. And we probably will see approvals of these in the near future. But for now, the indications are still diabetes and weight loss. So definitely something to consider in our patients who require weight loss in conjunction with other management options for their MASH. Cardiovascular disease risk reduction, certainly treating those cardiometabolic comorbidities, in particular treating type 2 diabetes, and also hypertension, dyslipidemia. Let's make sure that these patients have good control of these conditions. So when I'm talking to my patients about management, we talk about diet and lifestyle, but we also say we really want to make sure these other comorbidities of the metabolic syndrome are well controlled. So making sure we're working with primary care, endocrinology, cardiologists, making sure these patients have good control. And there's an asterisk here pointing out that MASLD and MASH do not increase statin risk of drug-induced liver injury. So we will frequently see our patients being referred in by their primary care cohort with elevated liver function tests. That's often the most common referral that we see, and end up finding out that these patients have fatty liver as the most common cause of those elevated liver function tests. But their primary care has stopped their statin. And really, we don't want our primary care cohort stopping these statins. In fact, AASLD has come out with guideline recommendations on not even monitoring liver function tests during statin therapy because the actual risk of drug-induced liver injury or DILI is really negligible when it comes to statins. So we would pour it in the water as hepatologists, right? We want to keep our patients on their statin therapy. And then obviously looking at how we can target MASH more directly, liver-targeted treatment. We're going to talk a little bit about vitamin E and pioglitazone, which came out of the PIVEN study. These are on our guidelines as possible options in certain patient populations. And then the first and currently only FDA-approved therapy for MASH with Resmetirom. We'll take you through some slides on that as well. So let's first of all go back to talking about these GLPs. So what's happening with GLP? So after food ingestion, endogenous GLP-1 stimulates glucose-dependent insulin secretion, suppressing glucagon and delaying gastric emptying. So that's how we get this direct acting on the hypothalamus to promote that early satiety. So these patients feel full more quickly and eat less, and it does work to reduce energy intake. So when we use GLP-1 receptor agonists, these are analogs of gut-derived incretin hormone, glucagon-like peptide, and they work to lower blood glucose and thereby causing weight loss. So what are we seeing as far as the role of GLPs in our clinics and hepatology practices? So I alluded earlier, we're studying GLPs in research for MASH, and semaglutide in particular is currently under review by the FDA for approval to treat MASH. There was a publication recently in the New England Journal of Medicine looking at the 72-week data readout that demonstrated benefit, improvement. But remember, it's not yet indicated specifically for treatment of MASH. So it's something to consider. We know that we're working on it. Likely we'll get approval when we're working with our endocrinology partners and our primary care. If they meet criteria for diabetes or weight loss management and a GLP would be indicated or could be utilized, this is something that we want to talk to our multidisciplinary team about potentially using these GLPs. How else are we seeing the effect of GLPs, though, in our practice? We're getting a lot of referrals from primary care and endocrinology regarding the side effects of GLPs that patients are experiencing, notably those that are taking GLPs for weight loss. So due to the delay in gastric emptying, when we are setting up patients for procedures, we recognize there can actually be an increase in risk of aspiration. So if a patient really has taken their dose of GLP within a week of their scheduled procedure, their upper endoscopy, their colonoscopy, there can be an increased risk with aspiration with anesthesia. So have to think about canceling that procedure. So a lot of GI practices now are putting in protocols for patients on GLP, having them hold their dose of GLP prior, at least a week or longer prior to these procedures. We're seeing this in surgery as well due to that risk. So vitamin E at the dose of 800 international units per day was studied in the PIVENS trial. This was a landmark study that showed vitamin E did improve liver histology in non-diabetic adults with NAFLD. So the indication can be considered for patients with MASH without cirrhosis and those without diabetes. So that's not going to be a vast majority of our patients, but vast majority of our patients do have diabetes. But in the PIVENS trial, there was an approximate little over 40% of patients showed histologic improvements and notably improvements in their steatosis. But not all patients responded, and we actually can't use this in our diabetic patients or those with hypertension. So in our guidelines, the 2023 AASLD guidelines suggest that vitamin E may improve NASH in the non-diabetic individual, while the triple European guidelines 2024 do not recommend it as a MASH therapy due to limited efficacy on fibrosis in particular and the potential risks. So what are some of those risks? Well, at this dose necessary to actually show some improvement in steatosis, there is some increased risk of bleeding. In particular, hemorrhagic stroke can be a risk. Also, a potential risk around concerns with prostate cancer. So it really does need to be limited to a certain population. We need to talk about these risks with our patients and long-term use with this high of a dose required. So again, it's an option, but there are some potential risks we need to think about. Pioglitazone, also studied in the PIVENS trial at a dosage of 30 to 45 milligrams per day, could be considered in MASH patients with or without type 2 diabetes in this particular medication. But the trial showed that there wasn't actually any benefit of pioglitazone over placebo for the primary outcome of improvement in histologic features of MASH. However, there were some significant benefits of pioglitazone observed for some of the secondary outcomes and notably improvements in cardiovascular risk. Again, there are some safety considerations around the use of pioglitazone. There's some potential risks of weight gain, and we know our patients with MASH don't want to gain more weight, they want to lose weight. Edema, bone fractures, especially in women, and a possible association with an increased risk of bladder cancer. So again, necessitating careful patient selection and monitoring. But again, vitamin E, pioglitazone, we do see these in the guidelines as potential options in certain selected patients. And then Resmetirom was approved last year on March 14th, 2024. It received accelerated approval by the FDA. We want to utilize resmetirom in conjunction with diet and exercise for the treatment of our adult population without cirrhosis, with moderate to advanced liver fibrosis. So those stages of 2 and 3. And this is a thyroid hormone receptor beta agonist. So it works by selectively binding to and activating THR beta receptor in the liver. So what's this thyroid hormone, beta? You might not know this, but we have thyroid hormone receptors in the liver, in particular beta receptors. And when we have MASH, when we have fatty liver, due to the inflammation and potential fibrosis, we get what we call kind of a relative hypothyroidism in the liver. So THR beta agonism, or resmetirom, works by agonizing or stimulating these receptors in the hepatocytes, in the cells in the liver. And in doing so, they have pleiotropic benefits, and notably reducing fatty acid oxidation and reducing intrahepatic triglycerides. So it works with positive benefit on reducing lipids within the liver, and then indirectly reducing inflammation and potentially fibrosis. So the Maestro-NASH is actually an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. And the trial studied adults with biopsy-confirmed NASH and fibrosis stages F1B, but F2 and 3. And it's an ongoing study. So I mentioned it received accelerated approval because of its benefits at 52 weeks, but its ongoing 54-month trial will look at further benefit on overall mortality morbidity, as well as liver-related mortality morbidity. So 966 patients were randomly assigned in a 1:1:1 ratio to receive resmetirom once daily at 80 milligrams, 100 milligrams versus placebo. And the dual primary efficacy endpoints at week 52 required that patients showed resolution of their NASH, including a reduction in the NAFLD activity score of at least 2 points or greater, with no worsening of their fibrosis, and needed to show an improvement or reduction in fibrosis by at least 1 stage or greater, with no worsening of NASH. So it had to meet both of those endpoints. When we look at safety in the Maestro-NASH trial and the phase 3 trial, diarrhea and nausea were the most frequent with resmetirom over placebo, but the incidence of serious adverse events were actually similar across the trial. And diarrhea and nausea were fairly mild and transient, occurring within that first month. And then here's the primary efficacy endpoints. Resmetirom at 80 and 100 milligrams were shown to be superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least 1 stage. And so when we look at NASH resolution with no worsening of fibrosis, we see this on the left of this graph, nearly 26% in the 80 milligram arm, 30% in the resmetirom arm achieving this endpoint versus a little less than 10% in placebo. And then when we look at that second endpoint of improvement of fibrosis by at least 1 stage or greater with no worsening of NAFLD activity score, again, a little over 24% in the 80 milligram dosing arm, nearly 26% in the 100 milligram arm versus a little over 14% in placebo. So what are some of the practical considerations for managing patients with resmetirom? So that ideal patient for treatment is really that adult population without cirrhosis with moderate to advanced liver fibrosis, so stages 2 and 3. And remember, this is only approved in conjunction with diet and exercise. So we still want our patients working on healthy diet, regular exercise, and weight loss. Some other practical considerations for managing patients with resmetirom. These are some important drug-to-drug interactions to be aware of. So medications to avoid are those that are strong 2C8 and or are organic anion transporters, polypeptides of 1B1 and 3. And I guess I'll point out, cyclosporin, gemfibrozole, maybe something we see once in a while, but a lot of these medications, clarithromycin, we might see more often. A lot of these medications on the lists are going to be our antiretrovirals, so treatments for HIV. We're not going to run into this very often. Tolerated with resmetirom dosing, but we want to think about dose reduction with resmetirom. The most important probably here is clopidogrel. So those patients based on weight-based dosing, that would be on the 100 milligram dose of resmetirom normally. On clopidogrel, we're going to reduce that to the 80 milligram. And those based on weight-based dosing, that would be normally on the 80 milligram. There's actually a 60 milligram dose of resmetirom available if we have to dose reduce based on these concomitant drugs. And notably, we'll find clopidogrel probably more frequently. And then medications that are actually at increased risk of exposure due to resmetirom are listed here on the right. And I'll point out most importantly would be the statins. There's a maximum statin dose that they recommend or that should be given when we're dosing with resmetirom. And that's pravastatin and atorvastatin should be a max dose of 40 milligrams, and simvastatin and rosuvastatin 20 milligrams. So we don't want to go greater on those doses because you could have more side effect, statin side effect. So other practical considerations for managing with resmetirom: duration of treatment and monitoring. We want to see what the ongoing MAESTRO-NASH trial will show with this, but we, in kind of day-to-day practice, will likely want to be restaging our patients, at baseline, treating the patients with resmetirom, and then periodically restaging with non-invasive tests. And I say what you have available is what you should use. And if that's VCTE or elastography technique, if you're able to access PDFF by MRI, or simply a blood test such as ELF, whatever you use at baseline is what you want to repeat. And if you have availability to do more than one non-invasive test, there's a really good guideline that came out for ASLD around the use of resmetirom. What is the indicated population, and how do we want to monitor for both safety and efficacy, so response? So I would reference you to the 2024 updated guidelines from ASLD, which is a really nice flow chart. And when do we continue treating with resmetirom? And when do we consider stopping? So again, expert panels are continuing to work on cut points and periodicity for testing. And these are the questions that still remain. So widespread use of resmetirom really will depend on insurance coverage, and how often do we want to repeat staging and lab tests for monitoring? And again, referencing that ASLD guideline. We'll need duration of treatment recommendations, and when do we stop treating? If that patient has really a great response and they reduce their steatosis completely and their fibrosis stage, where do we go from there? And it's also important to recognize that we have multiple agents currently in clinical trials, so we'll likely have many options in the future and likely be using therapies in combination. So for more information, please visit the GHAPP MASLD and MASH Community Network for additional disease state education and the Resmetirom webcast. And thank you for joining. And if there's any questions, feel free to go ahead and ask at this time.